My name is Sandro Galea. I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. Welcome to this public health conversation. These events are meant as spaces where we engage with the ideas that shape a healthier world. They're a forum where we discuss, debate, and sharpen our thinking about the issues that matter most for health. Thank you for joining us for today's discussion. Today is the latest event in our Challenging Public Health series. The goal of the series is to cast a critical eye on the work of public health during the COVID moment. We do so to see where we performed well and where we fell short, with the aim of learning to do better. We are guided in these reflections by expert speakers who hold up a mirror to ourselves to see how we might improve. Today, we have the privilege of welcoming a speaker who has done much to support the vision of equity in public health globally. Dr. Seye Abimbola is a health systems researcher from Nigeria. He is a senior lecturer at the School of Public Health, University of Sydney in Australia, where he teaches and studies knowledge practices in global health, health system governance, and the adoption and scale-up of innovations. He is the editor-in-chief of BMJ Global Health and the 2020-22 Prins Claus Chair in Equity and Development at Utrecht University in the Netherlands, where he is working on epistemic dignity and justice. So in terms of the format of this event, I'm going to turn it over to Dr. Abimbola, who is going to make a few remarks. Then when he finishes, I will ask him some questions, and then I will also moderate questions for Dr. Abimbola from the audience. Would encourage you to put in questions in the Q&A, and I will moderate that after Dr. Abimbola and I have a back and forth. Seye, welcome. Thank you for joining us. It is 6 a.m. in Australia for everybody, so we're particularly grateful, Dr. Abimbola, for joining us. Seye, over to you.
Thank you very much, Sandra, and thank you for having me, and it's very nice of you. What I'm going to do is reflect a little bit in a mostly disjointed way about how I've sort of made sense of how public health has performed in the light of COVID-19. And I will start to do that first from my position as an editor of a global health journal in the context of a pandemic, and what I have taken away from how journals and the academic publishing infrastructure of public health has performed in the pandemic. And then I will reflect a bit also from the perspective of someone who has watched sort of public health, global health in the last 20, 30 years, and sort of, again, try and reflect on how COVID-19, how we responded differently to COVID-19 because of how we've had to respond to things in the past. And then I will talk a bit about how we think about methods and the language we use in global health more broadly in the context of equity. So three sets of things, and I hope to be very brief. So the first one was in relation to my role as an editor. So first, right around sort of April, May 2020, when the pandemic started, a few things happened, and I suspect the same sort of things happened to other journal editors or journals, which was that submission rate increased astronomically immediately, sort of in the first few weeks, which meant that we had to have an editorial set of decisions that were clear about what we would take through peer review or even consider publishing. And there was a set of papers that were very, very reactive on the go, trying to sort of influence in commentary form what was going on. And it was clear that those are not the kinds of things we wanted to publish. Everyone had an opinion, everyone wanted their opinion published. There was just no space to do that. And frankly, we didn't think many of them were important or relevant. And I'll come back to discuss what all of this mean for the structure and nature of academic publishing. The second set of papers were those that we knew were sort of analysis of data, but that we knew would be sort of irrelevant, outdated within 2 to 6 months. And it was clear and easy to see that once the pandemic started, that there were just these good papers, methodologically sound, but in 6 months things would have moved on. What was the point? And the third set of papers, which were the ones we really cared about, at least at the beginning, were papers that were trying to think about the future. What does this mean for the future? From the perspective of the past, how has what's going on now been a continuation or a discontinuation from the past, and how do we build back differently in the light of the pandemic? Now, a few points to reflect on in the light of that. sorry, there's one more category, which were papers that were aimed at decision making in the immediate on COVID-19. So, for example, papers about sort of is non-pharmaceutical interventions effective, XY, sort of papers that were important, or modeling papers, but many of them were modeling papers. What should we expect? How should we prepare? Now, something that struck me immediately as important was that the most influential of those papers already had their impact in the real world before they were even submitted to a journal. In other words, and I don't think that was peculiar to the pandemic. In fact, my sense has often been that the most important and consequential research in public health have had their impact very often before they're published. They're often done in collaboration with people who are decision makers. They're often done in response to immediate needs. And I find that those are generally the most consequential papers. Now, not always for good. I mean, there were people who were hanging out in sort of number 10 Downing Street, who were influencing decision-making on the go in the UK, for example, whom we know in retrospect were probably informed by the wrong assumptions or problematic assumptions about how the world works. But still, those are the kind of papers that are most consequential and impactful in public health. And it made me sort of think a bit more clearly about what role journals have anyway, right? That if in the context of a pandemic, we're serving the role of legitimizing already done work, already impactful work. If that's one of our roles, then we need to slightly reimagine how it is we do the work that we do. Because often what we say to ourselves is that we are sort of trying to rush to publication. We are trying to publish things so that they can be impactful. But sometimes and very often, and certainly in the context of COVID-19, that was often the case, especially at the beginning. We were just rubber stamping what already had done its work in the world. The other bits, one of the categories of papers I mentioned were those that were sort of in the immediate, things will likely change. Now, those papers deserve to be published. We just didn't publish them, in part because, again, there's this set of thoughts that came to mind for me about the role of a global journal. That there's something to be said for building local journals within spaces that are immediately responsive and serve the needs of a particular space. Which was a thought that is in many ways linked to my reflections on decolonization. For me, one of the big gaps we've had historically in academia generally has been to set the eyes of everyone to the West. There's a sense in which if I do work in Nigeria or Zambia, the person I'm trying to impress is somewhere in London or Boston. And that is deeply, deeply problematic. And I think about that a lot. And again, I thought about that a lot in the context of COVID-19, that some of the most, again, important responses and reactions and articles were articles that were meant for and most impactful within certain specific local spaces. And are no less important for that. Right? The fact that the BMJ or Lancet wouldn't publish them, or in fact, in my view, shouldn't publish them. Because in many ways, to publish them is to distract from what ought to go into a certain space and the responsiveness within that space. And that doesn't make them any less important than something that the Lancet or the New England Journal of Medicine will want to publish, for example. And very often for me, I found that the kinds of papers we want to publish, the ones that are sort of more global, quote and unquote, papers speaking to sort of what the WHO should do differently, papers speaking to the, colonial underpinnings of some of the ways in which you do things. While they're important, they were speaking to this, vaguely defined global space. And in my head, I was trying to make sure that I wasn't even imagining that space was any more important than what ought to happen, say, within Lagos or what ought to happen within Lusaka, right? Because those spaces are just as important, if not more important. So those are sort of broadly, reflections on how, for me and my role as a journal editor, and the role that I think journals play within the public health knowledge infrastructure, and how we need to begin to think in many ways about local journals being an important component of stronger systems. in health. It's not traditional that we think about local journals as health system strengthening or system strengthening, but that's how I think about them now. And again, I hope we go into this further in the discussion session, because it's something I worry about a lot. That there is a sense in which the knowledge infrastructure of public health and global health is oriented to the West. And if I'm trying to serve something that a journal editor or an academic institution in the West will find impressive, I am almost by definition doing a disservice to what someone in Lagos, someone in Lusaka will need and find impressive, because those people are different and their expectations are different and what they care about are different. And I want to serve the person in Lagos or Lusaka primarily. So first set of reflections about journals. The second, something that I've been thinking about a lot throughout the pandemic, it's also how in public health, as much as we talk about equity, I don't think we know how to think and talk about it very well. And I say that in part because of what I've observed about how we talk about things being effective or not effective, right, in context of the pandemic. So in public health, one of the ways in which you think is if something works for 80% of the people, 90% of the people, it's good. And it's to be rolled out. If something, that 10%, 5% becomes in many ways a secondary consideration. And that's in my understanding how a lot of public health works. And if we are concerned about equity, we need to find ways to talk about the people for whom people are not in the mainstream, basically. And I can understand how it is that we think that way. A lot of the history of the field, a lot of those who have been prominent in the field have been people who have been privileged enough to be in the mainstream in many ways. And when you are in the mainstream, and if something works for the mainstream, it's much more difficult to think about those who are not in the mainstream. Now, at the same time, it's also important, which is why this is why I really think the issue and the challenge is, if people who are in the 5% or 10% or 20% of the population also want something that perhaps 80% of the people do not want, how do we have a sort of a deliberation, which is a moral deliberation in many ways, in the public, by the public, to ensure that the needs of the 20% are being fulfilled? And I'll make this slightly more concrete. So I live in Australia currently, and when you survey public health professionals in Australia thinking about the pandemic, there's a group of people who are staunchly of the view that the pandemic is pretty much over, and it's time to move on. There are people who are dying, but there are people who might die anyway. Maybe they are dying slightly earlier, maybe they are dying of a different cause. There are other people who will die, but looking after them is not worth the cost of taking any population level action on the pandemic. And those people hold those views very strongly, and they share those views publicly and make the case. And there are those who think very strongly that the pandemic is over, that if people are still dying, then it's very important, that long COVID is a big thing, that we still have to, function as though the pandemic continues, and to react and respond and be on the front foot. Now, what I found remarkable about this tension, this schism, this sort of separation, in my view, has been that each group believes that they're absolutely right, and each group believes that the other group is absolutely wrong. And I think I often find myself blaming how we were trained in public health for that. I don't think public health trains us want to think about how to reconcile the needs of the very small minority, or not very small, the minority, with the preferences or the needs or the desires of a larger majority. But also, we're not also trained very much to think about uncertainty in a very serious way, right? That if we don't know what's going to happen tomorrow, what should we do now? Now, people evoke all sorts of principles, but those are debates that I often wish public health people we're trained to have and to have from the get-go. And I think we need to think about this a lot more going forward into the future, because the requirements and demands and debates about equity will only become more and more important to have. Now, the last point I'll make, which is a smaller point, is something broadly that I describe as epistemic injustice in the work that we do in public health, which is related to my second point. Where do our research questions come from, for example? There is a sense in which we defer to the literature, which is an important body of knowledge. But at the same time, if we work in spaces, and against one of the reflections that I have from COVID-19, if we work within situated circumstances and in locations, people in those circumstances and locations know a lot more than the literature. But we are optimized in many ways to fill gaps in the literature. And when we do that, one of the things we do is to deny the knowledge that people in those spaces and situations hold, and to almost erase what their learning needs and knowledge needs are by default. And I think we function in public health in that way by default, because that's how, again, we were trained. And the second part, again, which links to my earlier point, is that people in those spaces and situations are not just holders of knowledge, they are also interpreters of knowledge. They have frameworks of making sense of the world. But again, we defer to our own dominant frameworks of making sense of the world. And going back to the COVID-19 majority-minority example, that one of the challenges that I've found in trying to make sense of the discourse in that space has been that people's views and arguments often reflect their standpoints. In other words, if I am a person who, for some reasons, is at high risk of mortality from COVID-19, for example, my analysis of the situation becomes significantly different. Or if my mother is, or if my child is. If I am lucky enough to be in a situation where I don't have to worry at all about those, my analysis becomes also different. And the ways in which I process and make sense of and interpret the data that are right in front of me are also different. And I'm really interested in how we begin to think about a public health, global health field in ways that take seriously that fact, that people within spaces, people, especially those who are on the margins, for whatever reason, have their own ways of making sense of the world. And when we seek to intervene, when we seek to analyze, when we seek to make sense of their reality, that we must, at the same time, be taking into account how they make sense of that reality, no matter how minority those views are, and no matter how less powerful they are relative to us, who often are in a position to act, to address inequities. We address inequities from a distance, whether it's geographical or social. And it's important to recognize that that distance often make us prone to these epistemic injustices, whether it's in terms of not fully regarding the knowledge people hold or the ways in which they make sense of their reality. And if we are going to be working on equity in public health, we would have to be taking seriously that fact that we are at a distance and we know way too little. And as James Baldwin said, and I know, Sandra, you care a lot about James Baldwin. As Baldwin said, ignorance allied with power is one of the most ferocious enemies justice can have. And when more distant we are, the more ignorant we are. And often because we are distant and because we are doing public health and working on equity, we have power. And power allied with ignorance, I'm always thinking of that, is a ferocious enemy that justice can have. Thank you very much.
Thank you, Dr. Abimbola. That's really, that was really, really terrific. I'm trying to decide whether to start with an easy question or with a difficult question. But let me start with a half easy question, then I'll move on to a difficult question, if I may.
Yes.
You talked a lot about health equity and global health equity, and I think we would probably agree that the term health equity is one that gained much currency and is used quite loosely these days. I was wondering if you can actually formalize your understanding of health equity, global health equity for us. Before then, I lead to my next question.
Yeah. There's the Conservative government in the UK, the current Conservative government. They had a framing, I think, under Boris Johnson, they didn't want to use the word equity. So they were using leveling up, which I found interesting in many ways, because I like it and because I don't like the government. It became interesting for me. And I like it because really what I'm thinking about in many ways is leveling up. It's saying that there are people whom structurally the world, society, communities have kept down. And it's important that we remove those structures and circumstances that hold them down so that we can level up, right? I like that framing of equity. And I like to focus on the structures, as I said earlier, that there are structures that hold people down. And it's important when we think about equity, for me at least, to focus on those structures. What are the things holding people down in whatever space? Now, for me, global health equity, again, global health as a framing is something I've struggled with for much of my career. And I like to think about it not just in terms of equity between countries, but also within countries, within communities, between even people. So when I'm saying global health, I'm often meaning, for example, what might happen within Nigeria or within my hometown, right? For me, that is part of the globe just as much as Australia is. And again, in saying that, I'm also focusing on the circumstances and structures that hold those people down, whether it's patriarchy, whether it's between men and women, whether it's colonization. So I live in Australia. This is a settler colony. There are indigenous peoples here. And there is a long history of that. Whether it is the forces of capitalism that sort of exploits people, all sorts of dimensions. And for me, what is important about this is that I could look at my community in Nigeria and see all of those forces at play. And I could shoot my eyes and look at Boston, and I'm sure I will see all of those forces at play. And I could look at Australia and see them too, which again, for me, goes back to the point of structure. That you know, anywhere in the world you go, one of the things that unify us, in a sense, is that these structures are almost always present, that lead to some people being structurally disadvantaged relative to others. And our task is to remove those structures, undo them. So
in many respects, we cannot think about health equity without thinking about the processes that lead to health equity or health inequity. Am I understanding you correctly?
Yeah, we cannot. Yeah, we have to think about the processes that lead to inequity, and those processes are grounded in the structures that that determine how those processes play out, right? So we have to. So as much as equity often makes us want to think about individuals, I'm always trying to think about the structures more than I think about sort of individuals, because often it's the structures. People, yeah.
Sorry, I didn't mean to cut you off. Apologies.
I was going to say that people, one of the big problems we have in public health, in my view, is that we are optimized for thinking about individuals, even though we claim that it's a field about population. Very often we are still thinking about individual behavior, lifestyle, what people choose to do, behavioral change. I'm always thinking about let's shift. That's not the theater of action for equity.
So let me ask a question, which is something which I've struggled with in my career, and I'd be curious about your input. So one recognizes certain structures, deep structural forces that need to change in order to improve health systemically and to narrow health gaps. But of course, one also recognizes that those deep structural forces take a long time to change. It is fanciful to think that those can change overnight. So one thing I've struggled with, and I've written a little bit about this, is to what extent does work on the smaller, more particular efforts that one knows are only going to make very small impact, but at least it's impact that is felt close, more proximally in time. To what extent is that work warranted, balanced against the longer term effort of changing structures? Or to what extent is the work on the proximal a distraction from saying, we just shouldn't do that at all and just focus all our energy on the structural?
So I think about this in terms of, first, attention is near zero sum, if not exactly zero sum. In other words, if I'm focusing on this, I'm not focusing on that. I also think about this in terms of priority. So I very much like to use the framing of primary and secondary, or primary and subsidiary. Often because a lot of what I'm trying to say is not, don't do this, do that. But it's like, prioritize this and do less of that. And it's very easy to get caught up in the framing of saying, you know, don't do this, do that. But often what I'm trying to say is do a lot more of this and less of that. And I think that goes to the heart of your question. I think the more of the proximate we do, the less attention we can give to the structural. I think the structural needs much more attention than the proximate. I think very often the proximate will get us somewhere, but little, really, really little. And the ways in which we work in public health has often meant that those little, because they're easily demonstrable, we can easily establish causality, we can easily sort of make claim as to, you know, the impact we've had. They attract way too much of our attention, disproportionately too much of our attention, both methodologically and just, you know, substantively, too much of our attention. And we give much less attention to the structural things. And I give a good example of this, again, as a scholar, that I know, for example, that if my research project of my research career is geared towards serving the knowledge needs of activists, right? The kinds of questions that I will be asking, the methods that I will be using, and the kinds of innovations that I will be exploring will be completely different from if I think of my primary role as serving the needs of a practitioner, right? Or even a policymaker. Again, as another example of the ways in which I think we often get the balance wrong. I will focus more, I'm really hungry for a field that thinks of itself primarily as serving the needs of people who are trying to change structures.
Okay. So, sorry, go ahead.
I was, yeah, and that field would look very, very different from what it looks like today. And I believe very strongly, just again by observing how change really happens in the world, that we will achieve our goals quicker and better if we did that. And we'll make much less mistakes than we currently do.
So I'll come back to this, but let me now shift a little bit to the role of the academy. And I want to read a sentence that you wrote in a recent editorial. You wrote this: the academic global health literature has been a space for professors. It's time for that to change. What engages the attention of professors is not necessarily what advances equity in global health. So I'm a professor.
Yeah, I am too.
And as you are as well. And you know, I'm not sure about this statement. So I wonder if you can elaborate on it, and perhaps elaborate on it also, you know, with an eye to something which you've written about in other places, about the balance of expert voices and community voices. And then we'll pursue this for a second.
Yeah. So in that paper, so I had sort of 4 types of actors in a system in relation to knowledge. And I sort of positioned 2 of them as primary actors and 2 of them as subsidiary actors. And the primary actors are sort of activists and sort of practitioners. And the subsidiary actors are sort of policymakers and professors or academics. And what I've observed, and again from a very peculiar vantage of being an academic and a journal editor, is that the kinds of things that professors often want to do, in other words, the kinds of methods that catch our fancy, and the kinds of conversations we want to have, often among ourselves, are often very, very different from the kinds of conversations that people who are actually trying to change a system are trying to have. I was having a conversation with a friend and colleague 2 days ago. This friend and colleague works in the space of commercial determinants of health, which again is something that you think a lot about, Sandro. And this colleague said to me that they were at a meeting, a conference around commercial determinants of health. And they could easily notice just how pale the conversations academics were having among themselves to the ones that activists were having within a conference, within the physical space of a conference. And a point this person made was that the activists had a much clearer sense of how change happens within that space. and knew exactly what the next thing to do, and the next thing to do, and the next thing to do. And academics were much more interested in defining, describing, which are all important things, and important things that academics should do, right? But the point I was making in that editorial is that while important, that conversation itself will look different if we were having it with activists, right? It will look different. The things we are seeking to describe becomes different. Our theory of change becomes far more refined. So I do believe that very strongly. I could go much longer trying to explain, make a defense of that statement. And another example that I often think about is our obsession with randomized controlled trials, for example, for complex interventions. They are fancy, they give you fine estimates of causality, but they hardly ever change my prior, for example. In other words, if you do a trial about a series of interventions to improve to reduce maternal mortality, right? Say in India, if it doesn't reduce maternal mortality, it does not mean, I'm not convinced that you shouldn't do those things anyway. And if it improved maternal mortality, okay, well, there are things that make sense. And for me, the challenge is really, really what needs to be done. What are the people in that space in India? What do they want to know? And they're often not the estimates I'm seeking to generate. Yeah.
So let me build on that.
Yeah.
What's the role, if any, of population health science scholarship that is not directly linked to consequential action? What is the role, if any, of that in your view?
Again, goes back to my primary subsidiary distinction, right? So I would say 20%. It's important. I recognize, I do that sometimes myself. It's important, 20%. But I would wish that 80% of the attention is on the consequential one. I will never, ever make the case that that should be zero, because I love that too. And I love to read that, and I love to do that. But I also know that there's something about it that is indulgent, deservedly indulgent, but indulgent nonetheless. And I would wish that it was, 20%.
I love the specificity of that answer. I'm not even sure. I'm not even sure how to rebut that. So let me ask about. I have a couple of other themes, and then we'll get to questions from the audience, which I see there's some interesting questions. Let me get to the question of. You have the unenviable task of being the editor of a BMJ journal labeled with the albatross of the title of global health, based in a high-income country, and where, of course, 1/8 of the world's population lives, where, as you know, more than 90% of the authors come from. So the imbalance in terms of contributing to thinking about the health of global populations, using the term on purpose, versus where global populations are, is actually it's actually an extraordinary imbalance. And you've been very vocal about the need to address that imbalance, which I admire and I agree with. But I can't help but feel like we're dealing with, this is where we are, this is where we should be, and this is a multi-time unit project. So how do you navigate that in your head? How do you actually, how do you even tolerate that in your head?
Yeah. That's a very complex question, and I will try to answer it in a very disjointed way. I think the first thing I say to myself is that I must not forget that this journal ought to be much less important than it is. For the health of global populations, I like that phrase. It should be much less important. And the fact that it is far more important than it ought to be in the world is what bothers me the most, which is a very strange way to put this. But it is important way beyond necessity. And I really wish, so a lot of my activity is trying to undo that, undo why a journal set in London, etc., with British in its name, is as important as that. Now, And I think of how to make it less important in two ways. So there's two parts to my thinking about that. The first is I need to convince those who are in London and Boston and places like that, that they are not at the center of the world. Now, that's a very difficult thing to do. I'm not sure if you've tried to do that.
Well,
but
Boston considers itself the hub of the universe explicitly, so it is quite hard.
Yeah. So it's a difficult thing to do, to convince people. And often I find that my writing, my argument is to make that point as clearly and as unavoidably as possible. Now I'm not often successful at doing that. I'm often far more successful in the classroom doing that, with my colleagues doing that, than I am even as an editor writing editorials. But I think it's the first thing to do in this space, is to first make those of us who have imagined ourselves into the center, whom history has told are at the center of the world, to decenter ourselves from that place. Now, there's a second side to that, and I often like to use the metaphor that Ruth Bader Ginsburg popularized about all we ask of our brethren is to remove their foot from our necks so that we can stand up. And so there's the removal of the foot, which is, for me, it's convincing people in London and Boston that they are not at the center of the world, and that there's a case for them to shift. But there's the other side of standing up. So it's one thing to remove your feet, it's another to stand up. And you also find, again, I say this as someone who was born and raised in Nigeria, that we've also been educated for many, many years to think that London and Boston are the center of the world. So I also have there's also a corresponding task to make sure those people in Nigeria and places like Nigeria around the world, including Australia, to not think of London and Boston as being at the center of the world. So there are those two challenges. And the point I made earlier about local journals, for example, is partly trying to get to that, which is, so if someone, for example, in Nigeria wants to think of BMJ Global Health as the place as the destination of their work, or if someone from London goes to Nigeria and does work and thinks BMJ Global Health is the natural destination of the work, I want to be able to challenge that person and say, why is it not the Nigerian Medical Journal? Why are you not having a conversation with Nigerians? Because those are the people you want to be in conversation with anyway. Why are you coming to London or Boston? So for me, it's a difficult task. And a lot of these tasks have deep structural underpinnings. Making sure that Nigerian Medical Journal is as important as BMJ is a huge task. And again, it's a task that requires that BMJ itself understands that it's marginal. It's not at the center of the world. Also, that people who run the Nigerian Medical Journal are willing to stand up and say, well, we are here.
So a few years ago, I wrote in one of my books, inspired by the work of Geoffrey Vickers, who was a British physician, that the role of public health is to take things that we find tolerable and make them intolerable, to take things that we find acceptable and make them unacceptable. So how long is it going to take? And what role do you and I and everybody in this audience have to play? To say it is unacceptable that life expectancy in Nigeria right now is 54, 56, while life expectancy in Japan is 82, 83, which, I say that, and I think everybody in this audience says, yeah, we know that. But if you stop for a second, surely we can all say to ourselves, well, that should be unacceptable. Like we accept what is, to my mind, an enormous global health inequity because it's just how it is. How long is it going to take before we make that unacceptable? And what's it going to take?
I think it's going to take us being willing to see every human being as equal, truly equal. I don't think we do today. I don't think we've ever done. I think that's what it's going to take. And again, going back to COVID-19, I remember having conversations with some of my European colleagues and friends right at the height of discussions around vaccine apartheid and inequity. And I was saying to them that, did you know that your country has an extreme oversupply of vaccines and many other countries in the world do not. And these are medical people. And they didn't quite know. And I said, what will it take for that to change? And I said, it would take the average journalist in the Netherlands, in Belgium, to feel strongly enough about this. It would take for someone on the streets, people on the streets in Netherlands, in Belgium, to feel strongly enough about this, that it becomes a political issue in the EU, in the Netherlands, that, we have an oversupply some people do not have, that we have this high life expectancy some others do not have, that we've defaulted in many ways, as you say, to accepting these things as normal. And it would require a moral shift, a shift in the moral landscape of the world, to not accept this. And it would also, in many ways, require that those of us who know and think about this a lot, whether because of where we are from or because of whom we hang out with, that we develop language and frameworks and thinking strong enough, compelling enough to make this unavoidably salient to everyone. I think a lot about HIV, how we responded to the HIV epidemic, and how, for example, access to antiretroviral drugs took huge advocacy, mostly from South Africa, to change how we even think and thought about the pricing and the payment for antiretroviral drugs. And the need for a global agreement and global facility to ensure that people have access to those drugs. Now, in some sense, I think COVID-19 has meant that in responding to COVID-19, it was clear to me that there were lessons that we took from HIV, which is that the immediate need for having a global facility, the immediate need for realizing that there are people who are going to be left behind. The language wasn't as sharp at the beginning of the HIV epidemic, but for some reason, there had been a shift. And a lot of that shift, again, has come from people in low and middle income countries making noise. But I think that's the kind of moral shift that we need to make for that to be the case, for people to be uncomfortable. And I go back to language. In my work, for example, in thinking about knowledge practices in global health, I often find that I don't have the language because the language is not really there. That is simple, basic, clear, and compelling enough that I could sort of reach for and use in a 2, 3, 4 minute conversation. So there's a need to build a language, and I'm not sure we have that language yet. Just to make the point again and again, quickly, so that no one can have the excuse of not knowing or pretending to not know.
Thank you. I think the language of a moral shift and the language of creating a language is really interesting. I want to go down the path, but I want to ask a separate question. I know we're darting, but there's so many questions to ask. So I want to paraphrase something from Professor Veronica Wirtz, who asks the question about academic publishing. So, large publishing houses, BMJ Group, Elsevier, charge a lot of money and essentially ask researchers and contributors to volunteer their time. So the question is twofold. I think the first part is perhaps easier than the second part. So first is, do you agree with this unfairness of this business model, particularly as it disadvantages researchers in under cost constraints? And the second part, which I think is a harder part, how do you reconcile the dilemma to contribute to such a business model at the same time as you want to increase fairness?
There's a fine line, I'm not sure who said it. It might not be Marx, but it may not be, that there's no ethical production in capitalism. In other words, that there is, the business model is unfair. And there's no other way to describe it than that. I think as well, and I often am more quietly than I do other things, encouraging academics to fight against the business model. Academic publishing began in many ways as a platform for small conversations among people who shared common interests, right? From the very beginning in the 17th century in Europe. They were small, they were direct, they were to encourage connecting a system or a group of people to more of themselves, right? That was the purpose. I still wish that was the purpose. And part of my advocating for local journals to become dominant is for that purpose. That the most important thing a journal can do is to help connect the system to more of itself. And I also believe very strongly that to achieve equity, that's one of the most important requirements, to connect systems to more of themselves. I was talking earlier about 4 categories of actors: professors, activists, policymakers, practitioners, is to connect them to more of themselves. That is the job. In many ways, I think academic publishing has moved away from that, in part because of money. And because at some point in their history, they become less viable. Do I reconcile these two in terms of how capitalist and how extractive it is? No, I don't. I can't. The most I can do is to work very hard within that system to the extent that I can, for as long as I think I can do it well, to weaken that foundation and to direct people's attention elsewhere. And I think we're all complicit in this because we still feed that machine, and we can choose to do otherwise.
Thank you. I have a question from Kate Wright, which is a comment about training, public health training, and you made the comment about public health training. The question is, what might you see as 1 or 2 things that continue to perpetuate the challenges we have in public health training, and maybe conversely 1 or 2 things that we can do differently and do better?
I'm going to offend people by the first thing I say. I think too much of public health training is done by researchers. It goes back to our professor problem, right? That too much of training is done by researchers, and we train people almost implicitly assuming that they're going to do a lot of our training. Assumes people are going to do research, and that's one thing we could do differently. We could diversify the training just in terms of the kind of people who do it and the kind of things we're training people to do. The second thing in that regard is also that after all is said and done, we still defer to the biomedical. We still defer to the proximate. We still defer to all of this, to the most tangible things. And our training still isn't quite as focused on structures and the structure. Again, as I was describing this 80-20 thing, I wish 80% of public health training was a lot about structures. So those are 2 ways in which I would change. I would hope to seek to change how public health is trained. Now, there are much more specific things that I think about, one of which I mentioned earlier, which is the now I've lost my train of thought there, but something I mentioned earlier, I can't remember, but let's move on.
All right. Yeah. Let me ask you a question, which I think builds on what you were saying, and I want to read again from the same editorial, another sentence which struck me, which he said, "To be rigorous is therefore a cliche that demands universal truths or external validity, to default to uniform and standardized methods, metrics, indicators, and measures. But truth, in such a universal sense, is typically not the goal in the quest for equity."
Yeah.
So if you can unpack that a little bit. I mean, I thought there was a lot to agree and disagree with in that sentence.
If I want equity in Nigeria, there are certain things I will wrestle with. One of them will be, for example, the ways in which the medical training infrastructure was built to be as European as possible. The ways in which the primary healthcare system really doesn't look like Nigeria and Nigerians, which then creates this significant gap and distance between people and the health infrastructure that ought to serve them. If I want to change that in Nigeria, I will need to work through the kinds of people I need to convince, the kinds of strategies I need to take to convince them. I will have to map out whom those people are. and seek to convince them and change their mind. And this may be progressive, this may involve some activism, this may involve some lobbying, but there's a whole suite of things that we need to do. Now, if I wanted equity in the United States, I would need to map my strategies differently. I would need to think about the history of the United States in very peculiar ways. Now, there is a sense in which there are truths that are universal, in that there are truths that connect those two situations and circumstances, certainly. But I don't begin from there. I begin from the particularities of the circumstances and those locations, and I'm trying to work out what those are. Now, there's a level of abstraction at which those two connect. And at that level of abstraction, I've lost some important detail, right? And that's partly what I meant there, that there are things that are very particular, and those are the things that I care about, and I hope we care about more. And if we have to abstract, we get to a place where things look sufficiently similar. But at that point, we've lost a lot of detail. Right. So that's what I was getting at there. And if we began by trying to speak to and generate those abstractions, if that was our primary goal, one of the things we lose out are the particularities and peculiarities of the spaces in which we ought to be active and engaged in trying to generate, advance the cause of equity.
So let's shift to advice. Let's shift to advice. We have, on these public health conversations, we often have students who are listening in. So if you have somebody who is early in their, let's say still in their training, make it a bit easier, who is committed to, passionate about achieving a global leveling up, to saying it should be unacceptable that life expectancy gaps between countries, let alone within countries, we haven't touched on within countries, but we only have an hour, but we'll talk about that, is 25 years.
Yeah.
What would you advise them to do? What do you think? This is 2022. So let's say someone who's starting out their career, they have 50 more years of active professional career.
Yeah.
What is the most productive engagement that such a person can embark on at this stage in their career?
Where I often begin when I'm answering this kind of question, and this is a question that comes to me very often, is that at this stage of their career, it's very likely the time when they are thinking their most important and most radical thoughts. That the more senior they become, the more likely it is that they begin to mirror the system. For all sorts of reasons. If you are successful in the system, you tend to think that it's because you are well aligned with the system and the system needs to be preserved, blah, blah, blah. So there's a whole, so often it's at this stage that they are thinking their most important and most radical thoughts. And then there are others thinking those thoughts too at their stage. And it's very important to note that they are likely going to stop thinking like that in 10 years. So they need people to think with now, to hold themselves to account now, to perhaps even write down what they are thinking, publish them as an accountability strategy. I often feel that the things I write are the things that I want to hold myself to in 20 years or in 10 years, to work together to find like-minded people, and to begin to think and imagine and reimagine the field together. My feeling, my suspicion is that we are probably, and I suspect other generations think the same thing, but I can't help thinking it too, that we're probably at a stage where we can think radical thoughts and work together, and that change might be able to happen. And it's something worth believing. And as someone who is perhaps early in their career, to fight against the power of the system to absorb you and make you a version of itself, which this system will almost certainly do successfully if you are not on guard. So it's to be on guard, to try and change the rules from now, to imagine how to change the rules so that you don't have to be that person. And I say that as someone who knows many people who used to think certain kinds of thoughts, and the higher they go in the system, the less they're able to think them or speak them up.
Again, I have so many more questions. Let me Okay, I have one more question from the audience I want to ask, but let me just follow up on that one very briefly. Do you worry that can happen to you?
I do, which is why I said a lot of what I'm trying to do is to commit myself, in a sense, to say what I think as clearly and as honestly as I think them. And I'm sure people to hold me to them when I falter, if I falter. So I'm really very aware of that. And I'm trying to be on guard because it's very easy. But also to inhabit the contradictions and the complexities of my position. And someone, I think it was Veronica who asked the question earlier about the capitalist and extractive structure of academic publishing, which I'm very aware of. And again, it's something that I want to never get to a place where I believe it's okay. Even if I'm in it.
I like the term, the complexities and contradictions of one's position. Let me ask a last question from the audience, and then we'll wrap up from Shafi Koya. The decolonizing global health efforts. Do you worry, there's a question, that these efforts will end up merely shifting power away from the colonizers in, quote, the global north, to the powerful class and castes and groups in the global south? And what can we do to prevent that from happening?
Simple answer is, of course, I worry. I worry every day about that particular possibility. I also worry that often that question comes from the global space. In other words, there's a global space. There's a place where you and me exist, where we read global journals and publish in them. And I've often found that the most important conversations about decolonization are happening in other spaces. Whether it's in South Africa, whether it's in India, for example, whether it's in Australia, where I live, where if you were to listen to indigenous scholars and activists talk about decolonization, or people who are fighting the caste system of India talk about casteism in India. I mean, it's very easy, again, going back to London and Boston being at the center of the world, it's very easy to think this is the conversation. And I found, as an active participant, and in many ways a curator of that conversation, that is not the conversation, that the conversation is happening elsewhere. And that is what gives me confidence, that there are people who are actively aware of the global conversations and its potential negative consequences, and who are working actively in their different spaces and having a different conversation, so that they are sufficiently confident that such an eventuality is much less likely because those other conversations are happening. But even within the global conversation, there's something I've noticed, which is, again, that those who have a voice, those who use their voice, are often people who are either sufficiently comfortable, whether they are tenured or they are senior, and no harm will likely come to them. But there's another category of people whom I've had the privilege of knowing, who also use their voice, at the risk of losing their jobs, at the risk of being ostracized, at the risk of not getting the next promotion, and who still use it anyway. There are people whose bosses are threatened. People don't hear about this publicly, but I know them privately. So I'm really, really aware that even within the global conversation, there are those risks people are taking. And those people who are taking those risks are very, very aware that the conversation is not immune to being captured, and they are working hard against that. And I'm very happy about that.
Well, I want to end on one last question. I see somebody wants your attention, which is appropriate. 7 in the morning. Let's end on a positive note. Tell me, what gives you hope for health?
I probably, against my better judgment, perhaps even against the evidence, sometimes believe that human beings want freedom, and that freedom requires a certain level. That to want freedom is to want equity, and I can't think of those things without health being somewhere, big and important. And I have a lot of confidence in the human spirit to do that, to break its chains again and again wherever those exist. Now that is the evidence. In other words, that has happened again and again. Sometimes, not linearly. So sometimes it happens and then things go back, and then it happens again, things go back. But it happens and it continues to happen. And it gives me confidence that that will happen again and continue to happen. The second thing that gives me confidence is just how connected we are as human beings now compared to any time before, just how connected we are. And with greater connection comes, I think, a sense of seeing one another a bit more clearly. Again, we are far from that place where we see one another very clearly. But if we are going to care very deeply that life expectancy in Nigeria is 50-something years and in somewhere else it's 80-something years, it will require that we see one another clearly. And I think we are progressively getting to a place, I'm hopeful, where we will do that a bit more, and which means that we get more uncomfortable, which means we will see the need for freedom and we want to fight for equity as a people.
That seems a perfectly wonderful place to end. Thank you for what you do. Thank you for what you write. While Boston is far from the center of the universe, Sydney is far from the center of the universe, you have a lot of admirers here in Boston. With deep respect for your thoughts, and thank you for sharing them with us.
Thank you very much, Sam.
Always look forward to continuing conversation, Seye. Thank you for spending the time.
Thank you very much for having me. Thank you.
Good morning, and thank your family for letting us take you for an hour this early in the morning.
Thank you.
Good care, Seye. Bye-bye.
Yeah, bye. Thanks.